Good day, everyone. As a physician, I have spent years studying human health, metabolism, behavior, and the underlying science of obesity. Today, I want to offer a thoughtful, respectful, and fact based perspective on a question that has sparked endless debate. Is obesity a choice? It's a provocative question. It stirs emotions, it challenges beliefs, and frankly, it deserves better than a yes or no answer. Let's dig deeper. As a physician, I often hear the phrase obesity is a choice, spoken with an air of certainty. But when we dig deeper into the biology and lived experience of real people, we realize that choice is not a uniform or neutral concept. It exists within a complex framework of access, ability, and circumstance. When we say someone chose to eat unhealthy food, skip a workout, or not lose weight, we must ask ourselves what were the conditions surrounding that decision? Because while personal responsibility is a valid part of health, we cannot ignore the vastly unequal environments in which people are asked to make those choices. Consider this: two individuals may both have the ability to select what they eat for dinner, but one lives in a neighborhood with grocery stores, farmers markets, and safe walking paths. The other may live in a food desert where the only options are fast food restaurants and convenience stores. Technically, both individuals are making choices, but are those choices equally free? One is supported by a health promoting environment, the other by one that undermines healthy habits at every turn. Let's take it a step further. Think about time and stress. One person has a 9 to 5 job, childcare support, and evenings free for meal prep or gym time. Another person may be working multiple part time jobs, commuting long hours, caring for children or elders, and struggling to pay rent. Again, both can choose what to do with their time, but the cost of those choices is vastly different. Cooking a balanced meal or squeezing in a workout requires time, energy, and mental space. Resources not equally available to everyone. Then there's the role of chronic stress, which is often invisible. Stress activates the hypothalamic pituitary adrenal HPA axis, releasing cortisol, a hormone known to increase appetite and promote fat storage. Long term exposure to stress, particularly in environments marked by financial insecurity, discrimination, or trauma, can significantly alter how the body regulates weight. The mind body connection is not theoretical, it's physiological. When someone is coping with high levels of stress day after day, they are not just making poor choices, they are in survival mode. Mental health also plays a powerful role. Depression, anxiety, and trauma can lead to disordered eating behaviors, such as binge eating or emotional eating, and yet many people with these conditions go undiagnosed and untreated for years. In those situations, food becomes a coping mechanism, not a decision made in full control. Saying just choose better to someone struggling with mental illness is not only unhelpful, it's deeply unfair. We also cannot ignore the biological and hormonal influences on weight. People with conditions like hypothyroidism, insulin resistance, or polycystic ovary syndrome, PCOS, are biologically predisposed to gain weight and have a harder time losing it. Even among individuals without these conditions, our bodies each regulate metabolism, hunger, and satiety differently due to genetic variability. That means two people can eat the same meals, do the same workouts, and end up with very different results. Is that a matter of choice or biology? So, when we ask whether obesity is a choice, we must be honest about how layered and conditional that question really is. It is not simply about willpower or laziness, it is about access, biology, psychology, and chronic stress. It's about systems that make unhealthy choices the default and healthy choices the exception. Yes, people have personal agency, but that agency does not exist in a vacuum. Some are playing the game of health with a full deck, others with half the cards and no instructions. In medicine, we aim to treat the whole patient, not just the symptoms. And in this conversation, treating people with dignity means recognizing that choice in health is often shaped by forces far beyond an individual's control. As a medical professional, one of the most damaging patterns I witness is the stigma that surrounds obesity. It seeps into clinical settings, social media, family dynamics, and even the internal dialogue of individuals living in larger bodies. The idea that people with obesity are lazy, undisciplined, or lacking in self control is not only incorrect, it's dangerous. This stigma does not motivate positive change. In fact, it often makes things worse. Let's start with the psychological consequences. People living with obesity are routinely subjected to judgment, ridicule, and exclusion. This is not just occasional teasing. It can be chronic and deeply ingrained, often starting in childhood. Numerous studies have shown that children with obesity are more likely to be bullied, isolated, and even discriminated against by teachers or peers. That early stigma sets the stage for a lifelong struggle with self esteem, body image, and mental health. In adulthood, the consequences become even more serious. People with obesity are more likely to experience depression, anxiety, and disordered eating patterns. And contrary to what some believe, stigma does not motivate weight loss. In fact, it has the opposite effect. When individuals feel judged or shamed for their weight, they are less likely to engage in healthy behaviors. Shame leads to avoidance, not action. Patients may cancel medical appointments, avoid gyms, or binge eat in private due to the overwhelming feelings of guilt and failure. Now consider the healthcare system itself. Unfortunately, weight bias is widespread, even among physicians, nurses, and other medical professionals. Research has shown that some healthcare providers spend less time with patients who are obese, assume they are non compliant, or attribute all health complaints to weight without proper evaluation. I've seen patients with legitimate concerns like back pain, fatigue, or joint issues dismissed with a simple lose weight before proper diagnostics are ever performed. This kind of clinical bias delays care, increases mistrust, and can even lead to misdiagnoses of serious conditions like cancer or autoimmune disease. We must also understand the physiological toll of stigma. Chronic stress caused by weight discrimination can elevate cortisol levels, which in turn increases appetite and fat storage. This isn't speculation, it's a well documented neuroendocrine response. In other words, the very stress caused by being judged for weight can biologically contribute to weight gain or retention. It's a vicious, self perpetuating cycle. Shame leads to stress leads to weight gain, and weight gain leads to more shame. Beyond the individual, the cultural conversation around obesity often promotes unrealistic body ideals. Social media, advertising, and popular fitness culture glorify thinness as the ultimate measure of health, success, and discipline. When people internalize these messages, they may feel that their bodies are inherently wrong or unworthy. This can lead to crash dieting, extreme exercise routines, and other unsafe behaviors that ultimately damage health rather than improve it. Again, this has nothing to do with genuine wellness and everything to do with fear of judgment. As doctors, our role is to do no harm, and that includes protecting patients from the psychological and systemic harm of stigma. Our job is to offer care, not criticism. We must replace the reflect to blame with the commitment to understand. That means listening to patients with empathy, using respectful language, and focusing on holistic health outcomes like improving mobility, energy, blood sugar, or sleep rather than just weight loss alone. In the end, stigma is not just unkind, it's unscientific. It undermines trust, impairs care, and worsens the very outcomes we are trying to improve. Addressing obesity as a medical issue means looking beyond assumptions and stereotypes. It means seeing the whole person, their biology, their environment, their mental health, and offering treatment grounded in compassion, not shame, because every patient, no matter their weight, deserves to be treated with dignity. Obesity does not occur in a vacuum. And to treat it as solely a personal failure is to overlook the powerful role of the environment in shaping health outcomes. As a physician, I see every day how profoundly our surroundings influence what we eat, how we move, how we sleep, and ultimately how our bodies respond. We live in what public health experts call an obesogenic environment, a world that actively promotes weight gain and makes it increasingly difficult to maintain a healthy weight. Let's begin with the built environment. In many communities, particularly low income or underserved areas, access to fresh, affordable, and nutritious food is limited. These neighborhoods, often referred to as food deserts, are dominated by fast food chains, convenience stores, and liquor shops, but lack full service grocery stores with produce and whole grains. When your only realistic food options are processed, calorie dense, and nutrient poor, it becomes extremely difficult to make healthy choices no matter how much willpower or knowledge you possess. In parallel, opportunities for physical activity are also heavily dictated by one's environment. Safe sidewalks, parks, recreational centers, and bike lanes are not distributed equally across cities. In many areas, especially urban centers or rural communities, these resources are scarce, poorly maintained, or unsafe. Telling someone to just go exercise ignores the reality that for many, a walk in their neighborhood may not be a safe or viable option. This isn't a matter of discipline, it's a matter of access and infrastructure. Then there's the cultural environment. We are constantly bombarded by advertising for highly processed, high calorie foods. These ads are carefully engineered to trigger emotional responses, often targeting children and low income communities. Food marketing is a multi billion-dollar industry and it is not designed to promote health, it's designed to sell products. Sugary cereals, soda, fried snacks, and oversized portions are glamorized in media and normalized in daily life. These foods are convenient, cheap, and hyper palatable, making them both attractive and addictive. When people repeatedly choose these foods, it's not always due to lack of knowledge. Sometimes it's a conditioned response to relentless exposure and targeted messaging. We must also consider how workplace culture affects our health. Many jobs today are sedentary, involving long hours at a desk, often with limited breaks for movement. Add to that long commute irregular hours, shift work, and job stress, and you have a recipe for disrupted sleep, stress eating, and metabolic dysfunction. For people juggling multiple jobs or shift work, especially those in the service or labor sectors, the demands of survival leave little room for structured exercise or careful meal planning. Sleep, which is often underestimated in obesity discussions, is also shaped by our environment. Noise pollution, screen exposure, irregular schedules, and stress all interfere with sleep quality and duration. And poor sleep has a well established link with weight gain. It alters hormone levels like ghrelin and leptin, increasing appetite and cravings, particularly for sugary and fatty foods. So, when people are sleep deprived due to environmental or work related factors, their bodies are biologically driven to eat more and move less. Even stress itself, especially chronic stress related to financial insecurity, housing instability, discrimination, or social isolation, has a profound impact on weight regulation. Chronic activation of the stress response system elevates cortisol levels, which promotes fat storage and increases cravings for comfort foods. In many ways, the body is simply doing what it has evolved to do under threat: store energy for survival. When we view obesity through this environmental lens, the conversation shifts from blame to context. It becomes clear that many so called choices are heavily influenced, if not determined, by the systems and structures around us. Effective treatment and prevention require us not just to educate individuals, but to address the environments in which they live. That means advocating for policy changes, urban planning reforms, food access initiatives, and health equity. Only by changing the conditions that lead to obesity can we make healthy choices truly accessible for all. In clinical practice, one of the most important lessons I've learned is that health and weight are not always synonymous While excess weight can be a risk factor for many health conditions, it is not in itself a reliable or complete measure of someone's overall health status. Focusing solely on weight as a health indicator overlooks the broader, more accurate picture of metabolic function, cardiovascular fitness, mental well being, and lifestyle habits. It is entirely possible for someone to be classified as obese by body mass index BMI and still have normal blood pressure, stable blood sugar, healthy cholesterol levels, and excellent cardiovascular endurance. Likewise, there are individuals with a normal BMI who are sedentary, have poor nutrition, elevated stress levels, or metabolic syndrome. This phenomenon is sometimes described as metabolically healthy obesity or TOFI, thin outside, fat inside. It reminds us that appearance does not always reflect internal physiology. As physicians, we are trained to look beyond surface metrics. Yes, weight is a data point, but it's only one of many. In my own assessments, I am far more concerned about how a patient sleeps, what they eat, how much they move, whether they smoke or drink excessively, how they manage stress, and how they feel in their daily life. These behavioral and psychological factors often have a more significant impact on long term health than the number on a scale. Additionally, weight loss does not automatically equal improved health, especially if achieved through extreme or unsustainable means. Crash diets, over exercising, or using appetite suppressants may temporarily reduce weight, but they can cause electrolyte imbalances, muscle loss, hormonal disruption, and mental health struggles. In contrast, when a patient adopts sustainable habits like cooking more meals at home, walking regularly, sleeping better, and addressing stress, they often experience dramatic improvements in blood markers, mood, and energy, even if their weight barely changes. There's also an important psychological dimension to consider. When we focus exclusively on weight, we can unintentionally reinforce the idea that one's worth is tied to body size. This messaging is deeply harmful and can lead to disordered eating, body dysmorphia, and lifelong struggles with self image. I've seen patients who were made to feel like failures for not losing weight, even when their blood pressure had dropped, their blood sugar was controlled, and their stamina had improved. That kind of reinforcement misses the point of good medicine. Instead of telling people to chase a particular number on the scale, we should be guiding them to pursue habits and outcomes that improve their quality of life and longevity. Can they climb stairs without getting winded? Are they sleeping through the night? Is their mood more stable? Can they play with their kids, work productively, and enjoy their life without physical or emotional limitations? These are the questions that matter. There's also the issue of BMI itself, a tool often used to categorize weight. While useful for population level trends, it is a crude and flawed measure on an individual basis. It does not account for muscle mass, bone density, fat distribution, or differences across ethnicities. Relying too heavily on BMI leads to misclassification and at times mistreatment. We must always interpret weight in context. Ultimately, shifting our focus from weight to health allows us to practice more effective, compassionate, and inclusive medicine. It means we celebrate progress that doesn't always show up on the scale, like better lab results, fewer medications, improved mobility, or reduced pain. It reminds patients that their value is not determined by their size and that improving health is not about punishment but about empowerment. In doing so, we create space for more people to succeed in their health journeys on their terms and with dignity. When we think about solutions to obesity, the common response is to focus on willpower, discipline, and personal responsibility. While these elements do play a role in health behaviors, they are not sufficient on their own, and when used in isolation, they often result in frustration, guilt, and failure. In reality, the most effective way to address obesity is through a combination of compassion and science. This approach acknowledges both the physiological complexity of obesity and the human experience of those living with it. First, let's talk about science. Obesity is a chronic, relapsing, multifactorial disease. That means it is not simply the result of overeating or a sedentary lifestyle, though those behaviors may contribute. It involves an intricate interplay of genetics, hormones, metabolism, the brain's reward pathways, environmental influences, mental health, and even gut microbiota. Advances in neuroscience and endocrinology have shown us that the body actively resists weight loss through biological mechanisms. For example, when a person loses weight, their body often reduces its resting energy expenditure and increases hunger hormones like ghrelin, making weight maintenance extremely difficult. These are not failures of character, they are protective evolutionary mechanisms hardwired into the body. Knowing this, it becomes clear that eat less, move more is an oversimplified and often harmful prescription. As a physician, I advocate for evidence based interventions tailored to the individual. For some, this may mean structured behavioral therapy, support from a registered dietitian, or supervised exercise programs. For others, especially those with severe obesity or related complications, medical interventions like anti obesity medications or bariatric surgery may be appropriate. These options are not shortcuts, they are legitimate. Science based treatments that can improve health outcomes when used appropriately. But science alone isn't enough. Without compassion, even the most advanced treatment plans fall short. Many individuals living with obesity carry a lifetime of shame, ridicule, and internalized blame. They may have been dismissed by healthcare providers, judged by strangers, or made to feel invisible in public spaces. This emotional burden creates a barrier to care. I've had patients who delayed coming to the clinic for years because they were afraid of being judged. Some avoid gyms, social gatherings, or even family events because of how they feel about their bodies. That's why compassion must be at the center of our approach. It means meeting patients where they are, listening without judgment, and validating their experiences. It means replacing the question, why can't you just lose weight, with what challenges are you facing and how can I support you? Compassion allows us to build trust, which is the foundation of any therapeutic relationship. It also allows patients to feel safe enough to be honest about their eating patterns, emotional triggers, and barriers to change. Importantly, compassion also involves recognizing the broader societal and systemic factors at play. It means advocating for environments that support health, access to affordable, nutritious food, safe places to exercise, mental health care, and public policies that address the root causes of health inequity. We cannot expect individuals to thrive if the system they live in is working against them. When compassion and science work together, the results are powerful. We move from blame to understanding, from shame to support, and from short term fixes to long term health. This integrated approach doesn't just improve weight related outcomes, it improves lives. People feel seen, heard, and empowered. As healthcare professionals, community leaders, and fellow human beings, we have a responsibility to reframe the narrative around obesity. It is not a simple issue with a simple solution, but with empathy, respect, and evidence based care, we can make real progress. One patient, one policy, and one conversation at a time.